see, today we are going to learn something very important, and that is tracheostomy. Now, tracheostomy becomes highly important because that is the way you can save lives. One of the places where you can save lives is a tracheostomy. An emergency airway access is one of the most important things, and when you cannot intubate and cannot ventilate, you are left with only one option. You are left with only tracheostomy. There is no other option. If you cannot intubate, cannot ventilate, that means you cannot hold a mask and you cannot ventilate. You cannot intubate. You cannot intubate. Okay, when both of these are occurring, the only way you can do this is by doing a tracheostomy. There is no other way. There is absolutely no other way to salvage the patient. And once the patient gets hypoxic, then that patient remains GCS 3/15 for entire life. Their overall functional situation becomes extremely poor. You are aware of that, right? You are aware of that. So if a tracheostomy is not done in time, they take time to do a tracheostomy. The tracheostomy is not done well. There can be serious implications in the future. These patients will probably remain maimed for life. Remember this. They cannot get back to normalcy. So that's why understanding the tracheostomy is very important, because this occurs in an emergency situation. It will not occur electively. It is an emergency situation. And if you don't know how to do it, it is 100% guarantee that this patient will not do well. Because at this stage, you are in a situation where you cannot intubate and you cannot ventilate. You are in that situation. Okay, and you know that within 4 to 5 minutes, the brain will probably suffer. Within 4 to 5 minutes, the brain will suffer. So how much of oxygen you are giving, you have to get into the airway within minutes. If you don't get in within minutes, he is gone for life. He or she is gone for life. Clear? So tracheostomy has been described right from biblical times. Okay, it has been described in the Bible or in very early before Christ. There was certain prophets who actually put in a weed inside, a small weed that they got, and they actually ventilated and saved lives. Okay, so it is not it's not a new procedure. Obviously, over a period of years, it has been modified, remodified to an extent that we have two kinds of tracheostomies. Okay, you have percutaneous tracheostomies and you have surgical tracheostomies. So there are two absolutely different type of tracheostomies: percutaneous tracheostomies and surgical tracheostomies. All right. And when I say tracheostomy, even it also can be called as tracheotomy. So if you hear tracheotomy, it is the same as tracheostomy. Okay. However, a cricothyrotomy is very different from a tracheostomy. A cricothyrotomy is very different from a tracheostomy. Why? What is the difference between a cricothyrotomy and the tracheostomy? If I ask Hemant, what is it? Difference?
Sir, in cricothyrotomy we pierce the cricothyroid membrane. In tracheostomy we just cut the tracheal cartilage.
So in a tracheostomy you are going through the trachea. In the cricothyrotomy you are going through the cricothyroid membrane. That is the difference. The cutting of the cartilage or not cutting of the cartilage does not come over there. Clear? So when you say cricothyrotomy, means you are going through a membrane called as a cricothyroid membrane. And when I am saying tracheostomy, it means you are going through the trachea. Okay, through the trachea. Clear on this? So you should be clear in your mind what is a cricothyrotomy. This means to say, if I have a crico, I am just going through a membrane, means the fastest technique to get through would actually be a cricothyrotomy. If I am just going through a membrane, I am not going through muscle, I am not going skin, I am not going through the rest of the things that pass the neck, means what is happening? It is the fastest technique you can get through. That's why a cricothyrotomy is the fastest technique to get into the airway. Clear? Because you don't have anything. You don't require to dilate. You don't require to do anything. It's your in. The moment you touch it, you're in. That's why understanding the cricothyroid membrane by whatever techniques you want, palpation, by ultrasound, is an extremely important thing you must know. Understanding where so it's a lot of students that if a patient comes in and you feel this patient may require ventilation, I have already understood where the cricothyroid membrane is. It is always good to actually touch and figure out. So whenever I intubate my patients, the first thing I do is I put my hand on the neck to figure out whether I can palpate the cricothyroid membrane. Once I palpated, I know if this patient I cannot intubate, I can put a cricothyroid. You understand? The difference between a cricothyroid thyroidectomy and tracheostomy is also the size of the tube. Okay. Now in a cricothyrotomy, the size of the tube that you will insert will be very small. You can't insert a big tracheostomy into a cricothyroid membrane. You understand? So I may want to use the dilator of this particular tracheostomy. I may want to use the dilator of this particular tracheostomy tube, and just the dilator will be inside. You are understanding? Unlike a tracheostomy, so the hole will be very small. So classically, cricothyrotomy is usually used for emergency airway management. Clear on this? Any questions till now? Difference between cricothyrotomy and tracheostomy? Any questions? Any questions?
How much time we can sustain this?
No, so it is actually just a bridge before you actually secure an airway. It is only a bridge. Have we done it in this hospital? I have done it at least 4 or 5 times here in this hospital in the past. You know, in the past when we had situations where we just couldn't get the airway, so there was an earlier consultant over here. She has also done it, cricothyrotomy. And we had the habit of always touching the neck whenever we want to intubate, so that we know, okay, this is where the cricothyrotomy is. I mean, the membrane is. So once you know where the membrane is, you know for certain that I can get through very easily. It doesn't take too much of skill. It is very simple, because you have to just identify the membrane and go dead central. That's all that is required to do. Identify the membrane and go dead central. That is all that is required to do in cricothyrotomy. Okay, there is nothing more to be done in cricothyrotomy, and it secures there. So we have done it 3-4 times. I think not 3-4, only 3 times we've done it. But we did it. We have done it, and we know that we can get into that area very easily. Okay. So now, when you come to tracheostomy, there are 2 types: surgical and percutaneous. Percutaneous got its own number of types. So what is the first of all, why do you need a tracheostomy? If somebody asks us, what are the indications for tracheostomy? There are many indications. So what are the indications, Alia? So for an emergency, in an emergency, you may require a tracheostomy, but that is not tracheostomy, that is cricothyrotomy. You may want to do percutaneous tracheostomy also, it is fast enough. If you are very good at your work, percutaneous tracheostomy also can be done within 2 minutes, 2-3 minutes. But on an average, we say tracheostomy is in the right sense. Was the initial technique called a Siaglas technique, which takes around 10 to 15 minutes. We'll come to that. Okay, so you can for emergency airway access. Okay, then so normally when we say emergency airway access, we say FONA. What is FONA? Front of neck access. Front of neck access. Okay, because emergency airway access can be even endotracheal intubation through a bougie. Okay, so we normally say for FONA. Okay, front of neck access. Niharika?
Some oral surgery.
Yeah, so very important. So if you have an oral surgery that is done, and the anatomy is completely changed, everything has been repositioned and is suspecting that there's going to be huge edema, then they do a prophylactic tracheostomy in the operation theatre itself. Other way around, if you have an extremely bad trauma, something like a Lefort 3, there are Lefort grades of fractures, Lefort 1, 2, 3. So the Lefort 3 fracture, which is a fracture of the face, there person cannot breathe. So at that stage, you will require to have a percutaneous tracheostomy. Okay, so a percutaneous tracheostomy as an emergency airway access for elective procedures, post procedure. Then
prolonged ventilation.
Yeah, so prolonged. So what is the definition of prolonged ventilation, Ashok?
More than 7 days.
So by definition, what you're saying is right. By the NEGM definitions, it was more than 7 days. The NEGM actually went ahead and said tracheostomy is to be considered when the patient requires ventilation for more than 7 days. However, we are no longer looking at that definition. We are actually dividing early and late tracheostomy based on a trial called as a TrackMan trial. Okay, there is a trial called as the TrackMan trial, which you all should know the name TrackMan because it's a landmark trial that we did, that everybody did. There were more than 900 patients recruited in British ICUs all over Britain, and that is where they figured out whether it's early or late. But there the definition was 10 days. The definition was 10 days. Okay, so less than 10 days is early, more than 10 days is late. So when you say early, it's less than 5 days if you think about it. Okay, but when you say prolonged, it is more than 10 days. So you could say 7 to 10 days is what you could put it as, because NEGM says 7 days, the ANSIC's guideline says 10 days, and the TrackMan trial says 10 days. Clear? So when you say what is prolonged, you say anywhere more than 7 to 10 days. Don't say 7, don't say 10. Okay, because NEGM says 7. Okay, the TrackMan trial says 10, and the ANSIC's group says around 10. So prolonged, but why do you need it? Why do you need tracheostomy in prolonged ventilation? Why do you need it? Why?
Easy
So-
suction.
So dead space is not much of a problem. Yes, it will reduce the dead space, definitely. Then,
Easy suction.
Sorry?
Easy suctioning.
yeah. So importantly, the tracheal toileting becomes much more easier. Tracheal toileting becomes easier because no longer there is a larger tube to take out. There is a smaller tube that we have to keep patent. The smaller tube. So tracheal toileting becomes simple. Then. And when you say the dead space comes down, you need to say that the work of breathing probably will be a little bit lower as compared to the endotracheal tube. It's not much difference, but a very small difference would come there because there is Poiseuille's law. Poiseuille's law actually says that if the radius comes down or the length reduces, the resistance reduces by 4 times. It's like an IV cannula. It's like an IV cannula. The smaller the cannula, the larger the flow. The smaller the cannula, the larger the flow. That's where a central line has got low flow as compared to a peripheral line. A central line has got low flow of fluids as compared to a peripheral line. Clear? Clear? Clear, no? That's why a tracheostomy may cause a little bit of resistance, a difference, but it's not majorly clinically significant if you ask me. Okay? Then,
Post tracheostomy speech, it's less vocal cord injury or edema.
so prolonged ventilation can cause injury patterns. Now, what are the injury patterns that it can cause? It can cause tracheal necrosis. And if there is tracheal necrosis, these patients will be maimed for life, tracheomalacia for life. They will not be able to breathe. What is tracheomalacia? The cartilage actually falls like this. Okay, tracheomalacia, the cartilage actually falls like this. Okay, so the patient can't breathe at all for once you try to remove the tracheostomy, once you try to remove the endotracheal tube. So the edema reduces because it's no longer through that big tract. So the edema reduces, and that's why the problems of long-term endotracheal intubation comes down. Then you said tracheal toilet. So we've gone through tracheal toilet, we've gone through breathing, we have gone through the fact that injury to the trachea comes down. Then what are the other reasons?
We can discharge patient with the home.
So it is easier to wean off a patient. So what is known is that from the Trakeman trial, the same trial that actually looked at early tracheostomy versus late tracheostomy, was that we were able to wean off the patients 1.7 days earlier. You were able to wean off patients 1.7 days earlier. We can actually debate that trial in a big way, but this is what the end result of that trial was. The end result of the trial said that the days on mechanically ventilator support came down by 1.7 days in the group that was tracheostomized earlier. Okay, 1.7 days. Clear on that? So there may be a early, there may be a situation that you might be able to wean off these patients earlier. So when you say length of stay, that would probably then relate to a length of stay coming down. But yes, this is what you're basically telling, that you will probably be able to discharge them quicker. Okay, then you're right what you're saying. Then anything else? Anything else? So the mobilization of the patient becomes much more easier, no? So if you have a patient on an endotracheal tube, he's connected to a big tube that is connected to the ventilator. So mobilizing a patient with a tube on a ventilator is more difficult than mobilizing a patient with a tracheostomy tube. So mobilization becomes much more easy. Now with mobilization comes improvement in muscle mass, with mobilization comes improvement in general condition, with mobilization comes reduction in VAP, with mobilization comes reduction in DVT. So you've got a whole lot of benefits that come in as a result of mobilization. As a result of mobilization, there's a whole lot of benefits that come in when you're mobilizing your patients. Clear? So there's a huge benefit that comes when you mobilize your patient. Simple. Clear? Understood mobilization? Then, what else? Now this patient, once you have actually excluded the airway from the esophagus, can now actually eat food normally. If you have done a tracheostomy, okay, he is going to eat his food normally. Obviously, eating food is better than giving it through a Rice tube. So he may be able to eat food properly, which will stimulate saliva, which will stimulate his mastication activity, which will improve assimilation of food, which will give general feeling of well-being. Then, these patients can be put on a speech valve and made to talk. These patients can be put on a speech valve and they can be made to talk. So communication will improve. Endotracheal tube, you can't talk. You can't talk with an endotracheal tube in place. You can put a speech valve and they can start talking. You understand? So there are various benefits that actually comes with a tracheostomy, and you must understand which patient is which benefit you're looking at. Are you understanding? For example, why am I telling you this context? Because if you have a neuro patient that is coming in, you know that this patient is going to remain for a longer period of time. There, convincingly, I want to do the tracheostomy earlier than otherwise. In the context of what the illness is, why we require here, it's not for breathing, it is for tracheal toileting. It is for tracheal toileting. So I probably want to do the tracheostomy earlier. Okay, in these patients, early, when I say early, means somewhere around 5 days, maybe 6 days, I'll probably do it. Okay, but if I have a patient who's ARDS, who's having breathing problem, wait, no, कुछ फर्क नहीं पड़ने वाला है. इधर tracheal toileting का मतलब नहीं है. We are putting the airway for the patient so that the oxygenation is better. Wait, there is no hurry. You understand? If there is ARDS patient, this patient is not going to wean off in 1.5 days earlier. What is the entire thing? 1.5 days earlier he'll wean. This patient is ARDS is going to require ages. You understand? So in that time, take the right time to do a tracheostomy when it is absolutely safe to do it. Okay, and in that stage you probably want to wait. Okay, you want to wait for some time, then do the tracheostomy. There is no hurry to do the tracheostomy. You are understanding? Because you have the airway. The reason to put that is actually to oxygenate the patient much better. There, the risks of doing the tracheostomy becomes extremely high because of the hypoxia, because of the fact that there can be sudden desaturation, okay, because of the fact that these patients are inflamed, so the tracheostomy becomes a secondary inflammation that is coming on top of an inflammation that is already there. You are understanding? So there are various reasons why you want to defer a tracheostomy, and what was also noticed in the treatment trial was many of these patients that they waited did not require tracheostomy. 50% of the patients did not require tracheostomy, which they thought they may require tracheostomy. They were able to wean them and extubate them in daytime. You understand? That is why you can't take the trial directly on face value and say this is what you're supposed to do. That is why it is in the context of the patient that you must think, okay, this patient will require that will require a lot of clinical judgment to understand. It's not easy. It's not easy. Why it's not easy? You don't want to put a tracheostomy, a hole in the neck for anyone. Nobody wants it. Nobody wants it. Yeah? Nobody wants it. For life, you'll get the hole. You can see it for ages that that scar will be there for ages. Not something anybody wants. Clear? So now let's come to the differences between a surgical tracheostomy and the percutaneous tracheostomy. Okay, the preparation for both remains the same. So in the preparation for a tracheostomy, there are a few responsibilities that we should have. Okay, what are the responsibilities that we should always keep in our mind? One thing is that all the vital parameters should be seen. You cannot do the tracheostomy without having an EtCO2. You cannot do a tracheostomy without SpO2. You cannot do a tracheostomy without having blood pressure and pulse rate. You cannot do it. It is not possible, it is non-standard of care, and it is wrong to do something like that. So all vital monitoring has to be there. Second thing, you cannot do a tracheostomy without having difficult airway cart besides you. Okay, that means a laryngeal mask airway, that means bougie, that means stillhead, a bronchoscope at hands reach. So these are things that you require in these particular ultrasound. These are things without which you should not attempt a tracheostomy. You should not attempt a tracheostomy. Okay. Third thing, what you require? So you require entire emergency drug cart, which includes adrenaline, atropine, amiodarone, everything. You require everything that will require for an emergency drug. Clear? So to begin the tracheostomy, you need to definitely have all these equipments. The fourth thing that you require is you need to have so what are the equipments? Once more, let's go back once more. You require all monitoring equipment which includes SpO2, blood pressure, pulse rate, ECG and EtCO2. Okay, you require all of these on this particular patient. Second thing, what you require? The entire difficult airway cart it will require, which includes bougie, LMA, ambu bags and a bronchoscope. You require all of these when you are actually doing a tracheostomy. And the third thing you require is
emergency drugs.
all the emergency drugs, which includes atropine, adrenaline, amiodarone, everything includes everything you require at that particular place. Clear? So you cannot start a tracheostomy without having all these things. So these are the three things that you require. The fourth thing, can anybody tell? You cannot start a tracheostomy without looking at laboratory. Percutaneous tracheostomy cannot be done without looking at the laboratory findings. That means you are not supposed to do a tracheostomy in a patient whose platelet counts are less than 50,000. It is not supposed to be done. We take it as 80,000. Okay, the guidelines say you need tracheostomy. Your tracheostomy can be done if the tracheostomy is more than 50,000. Okay, however, we take it as 80,000. We don't want to even take that 50,000 because our patient at 50,000 will be much more lower because he is critically ill. That platelets may be not working as well. They may be platelet, just the number deficient is not the only, platelet function may be also low. Are you understanding? If the platelet deficit is there may be also platelet function problem because our patients are critically ill. That's why we want to maintain it at a higher level, maybe 80,000 is what we want to maintain. But guidelines mention 50,000. Clear? You can't have an INR that is elevated and do a tracheostomy. So you can't do a tracheostomy if your INR is elevated. You can't do it. It's not supposed to be done. Third thing, you can't have a patient in gross sepsis and septic shock with high supports and you're doing a tracheostomy. Not supposed to be done. The chances of having airway loss are very, very high. You're understanding? Airway loss and cardiac arrest are very, very high. So you don't want to do it when the patient is on NORAD, vasopressin, inflamed condition, very badly inflamed condition, sepsis. No, wait. Let the patient settle down a little bit because we know doing it early is not going to make a difference for me. We know that. Are you understanding? It's not going to make a big difference for me. That's why a tracheostomy procedure has to be well thought of before you go ahead and do a tracheostomy. It's not something you want to do urgently because this is not cricothyrotomy. It's not emergency airway access. Are you understanding? Clear on this? Clear? Any questions till now? Any questions? Any questions on the responsibilities as to what we should be getting before a tracheostomy? So we'll come to the procedure when we actually come to the procedure. We are not in the procedure yet. We just do the pre-preparation of the procedure. Okay. So pre-preparation is done. Now after we do this, then we first understand the difference between a surgical tracheostomy and a percutaneous tracheostomy. So what is the difference between a surgical? Any idea what's the difference and what is better than the other? So surgical tracheostomy and percutaneous tracheostomy, what's the difference? Come on, what's the difference? Anybody? You know what's a surgical tracheostomy? It is done in the operation theatre. That's one big difference, no? A surgical tracheostomy is done where? In the operation theatre. Percutaneous tracheostomy is done where? Bedside. That is one difference. Surgical tracheostomy is done in the operation theatre, whereas percutaneous tracheostomy is done in the bedside. Any other difference anybody can say? Absolutely, very important. So the percutaneous tracheostomy is cosmetically better. Why is it better? Because it is a hole only. It is a very small hole compared to a surgical tracheostomy, which is actually an incision that is long. You understand? So for life, this part is never going to be covered. This part is always going to be open. So for life, you will have a scar when you have a surgical tracheostomy compared to a percutaneous tracheostomy, which is a very small hole. A very small hole. Okay, so cosmetically, a percutaneous tracheostomy is better. Okay, then any more differences?
Chances of bleeding more
In?
surgical.
Yes. So the chances of bleeding are more in a surgical tracheostomy. So the approximate, when you say bleeding, when you say more, it means what? More than 25 mm. That is the cutoff. So whenever trials were conducted to actually look at percutaneous versus surgical, they considered accidental extubation, more than 25 ml bleeding, and critical events like cardiac arrest as a side effects. So anything more than 25 ml becomes high bleeding. Clear? It's not 1 liter and 500 ml that we think, because 25 ml means it can go into the airway and patient can choke and die. 25 ml. That is why more than 25 ml is high bleeding. And why does a percutaneous tracheostomy has less bleeding? Any idea? Because it's a small hole. Because it's a small hole. You are not cutting. You are not doing any cutting. You are only taking a small hole like an IV line and dilating. Isn't it? So there is no cutting anywhere. Since there is no cutting, the bleeding is much lesser. So the bleeding is lesser. Clear? The bleeding is much lesser. Then?
Chances of false patches more in surgical with complication.
The other way around. So if you were to not use bronchoscopy, if you were to not use ultrasound, then the chances of having a wrong placement, for example, lateral placement, are higher in the percutaneous tracheostomy because it's a blind procedure. It becomes blind the moment you have put it inside. The first up to the time that your wire goes inside, it is blind. Once your wire goes inside, then by a bronchoscope you can have a look and say it's open. Now you can actually visualize. You understand? You can visualize it up to, or you can visualize only after the wire goes inside. So up to that time, there is a possibility that you may be lateral. Though we are thinking we want to be dead central, there is a possibility you may be lateral because the tracheal size is only 2.3 centimeters on an average. So 2.3 centimeters tracheitis. So you may not go in the center, you may go to the side. Is there a problem going the side? Yes, there is. What is the problem going the side? If you go on the side, you might cause injury to the lateral tracheal wall. And if you cause injury to the lateral tracheal wall, there will be scarring, cicatrization, and then tracheal stenosis. You understand? There will be scarring on that particular area. There will be cicatrization, it means scar formation, and there will be tracheal stenosis. So you don't want to go lateral. You want to go dead central. So the position can't be, you can't search it like a central line. I'm putting here, I'm putting here, I'm putting here. It's not right. Because if you get it somewhere in the lateral wall, then you are creating a problem for this particular patient, because later on he will have cicatrization and laryngeal stenosis. Clear?
Sir, how we will get to know whether we have got lateral?
That is why you need to see properly anatomically. That is why you need to do ultrasound. You understand? That is why people say do bronchoscopy, because with bronchoscopy you can actually see inside where your needle has come inside. Up to the time that you have dilated, there is no. Up to the time before dilatation, you can actually change your position. Okay. Once you have dilated, then your the cicatrization will start. You understand? That is why understanding the anatomy is very, very important in these cases. Alright. Then, because it's a blind procedure, there is always a possibility that you might hit an artery. Okay, there is a possibility that you may hit an artery or a vein. Okay, you have the innominate artery there and the anterior jugular vein that passes over there. Okay, both these can actually be hit. If you hit that, there is no way you can do anything for this percutaneous patient, because you don't have diaphragm, you don't have cautery. You don't have cautery, right? You cannot do anything. You have to rush this patient down after securing the airway to the OT. Okay, so if it hits, that's why importance of actually figuring out very carefully where you are, and that is why the position is important as to where you're going to put the needle. The first needle puncture is so important, because that's where everything changes everything. Because going lower or going higher has a chance of hitting these arteries and veins. You understand? Then what is the difference between surgical? Cost wise, tell me the difference between cost. Cost? Nurses, can you tell me the difference between the cost? What is more expensive? Surgical. Why is surgical more expensive? You have OT charges. Exactly. You have OT charges, you have anesthesia charges, you have surgeon charges, you have OT charges, anesthesia charges, surgeon charges. Becomes very expensive worldwide. Worldwide, the OT is charged at a very high amount. Okay, so worldwide, the surgical tracheostomy becomes more expensive than the percutaneous tracheostomy. You might wonder the percutaneous rate is 20,000 rupees. But that's the total cost, apart from small things here and there. But in surgical tracheostomy, you may be spending around 5,000-6,000 rupees, but there is surgery cost that comes in 30,000, 25,000. You have OT charges per hour that is coming, anesthesia charges that's coming, which actually increases the entire cost. Clear? Then, apart from this, so there is a possibility in surgical tracheostomy that you normally may want to break the cartilage. You may want to break a cartilage over here to go in. Whereas in a percutaneous tracheostomy, you never do that. You go without breaking the cartilage but dilating the membrane between it. You understand? So you may not break the cartilage, so the chances of complications are much lower when it comes to percutaneous tracheostomy. Clear? The post-operative problems that you get are much higher with the surgical tracheostomy as compared to a percutaneous tracheostomy. Post-operative complications. When you say post-operative complications, I said decannulation. Decannulation is a problem with the surgical tracheostomy. Why is decannulation a problem? Why is the patient get accidentally decannulated? Because the difference is there. No, surgical tracheostomy is a scar. They have made a big incision. The tracheostomy is sitting on that big incision. You understand? It's a big incision. So the tracheostomy tube is sitting on that big incision. So the chances of accidental decannulation is much faster, much higher. Because what happens in a percutaneous tracheostomy is you made a hole and then you have shoved that tracheostomy inside and the skin is actually tightening around it. You are understanding? When you are doing a percutaneous tracheostomy, you are actually putting a hole over there, dilating. Now after you have dilated the skin goes back, elastic it is. So it will hold the tracheostomy. Since it holds a tracheostomy, accidental decannulation occurs less likelihood than compared to a surgical tracheostomy. That is why you may see sometimes when the surgical tracheostomy is done, they actually stitch the surgical tracheostomy to the skin because you're worried about it just coming out. That is one post-operative complication. Second post-operative complication with a surgical tracheostomy is because they have cut, the bleeding is higher post-operatively. Because they have cut, the bleeding is much higher post-operatively. That is why those patients who come from a surgical tracheostomy, don't wean them off immediately. Let them be down for a while. Do not move, do not do anything. Come for surgery, wait. Next day morning, start weaning them off. Whereas in a percutaneous tracheostomy, start weaning off because early post-operative complications are less. Early post-operative complications are less. So that's the difference. In a surgical tracheostomy, patient comes to the ICU after a tracheostomy, leave him like that for 1 day. Next day morning, see what is happening. Right? Whereas the percutaneous tracheostomy, do the tracheostomy, wean him off in 4 hours. You don't require to wait because the early post-operative complications are much lesser. Clear? Clear on this? The other thing in surgical tracheostomy is the fact that you may be subjected to bleeding. That is another complication which, because of the incision and the bleeding, there is going to be an increased incidence of infections. So we are worried about infections in a tracheostomy that is done surgically because the incision is big, bleeding is there, and it is a stressful procedure. Whereas in a percutaneous tracheostomy, the bleeding is less, the incision is smaller, so the infection rate is much lesser. Clear? So it's not to be done, no? It's not to be done. That is why we don't want to do a surgical tracheostomy. The only places where a surgical tracheostomy is required is when you can't do the percutaneous. So which are those cases? Which are those cases?
Short, very short.
Yeah, the anatomy is not good. We started by saying I must know the anatomy. So if I can't get the anatomy right, I don't want to attempt a percutaneous tracheostomy because the risks will be much higher. Are you understanding? The risks will be much higher. You got the point? So in a patient in which I can't do a surgical tracheostomy, in that patient, I like, for example, you've got a severe burns patient. I have a severe burns patient, all it is burnt. I can't even palpate the trachea. When it's burnt, everything becomes like hard, you know. You can't even palpate anything. So when you cannot palpate the trachea, I don't want to do it percutaneously. I want to do it surgically. You understand? If the patient has got a very difficult anatomy, very large neck, difficult to palpate the trachea, or maybe you have some kind of surgery that is done, some kind of major surgery that is done. Those are those patients in which there will be change or difference in the place where the tracheostomy is lying. So there I want to do a surgical tracheostomy. Okay. Electively it is done in the operation theatre because of the surgery that is there. Because of another surgery that is there. But otherwise, in present scenario, there is really no indication to surgical tracheostomy. It's wrong to do it, in fact, because you're subjecting the patient to a lot of other problems. You are understanding? Are you understanding? It is wrong to send the patient to the operation theatre to get a tracheostomy. Now you are clear why it is wrong.
But the anatomy is also difficult. We can't do bronchoscopy guided.
No, because the first up to the fact that you enter into the trachea, it is blind. You understand? Up to the fact that you enter, the bronchoscope is only to figure out where the tip of the needle is. The bronchoscopy is only to figure out where with the difficult anatomy, I will not even reach that time. You understand? By the time I touch here, there, I'll need one artery, one vein, one this, we don't know where you are. You understand? So, till that time, it is going to be dangerous, right? By that time, you'll make all holes everywhere. It doesn't make any sense to do something like that. Clear? Am I clear on this? So that is why a difficult anatomy cannot be tackled by a percutaneous tracheostomy. That should be very clear. Don't think it's a challenge for me to do it and I will do it. No, it's not. It's not right to do that. Send it for a surgical tracheostomy where it is done under controlled condition and they open, they cut, they see. They open, they cut, they see, and then they put. Clear? Any queries till now? Any queries? We've just understood the difference between surgical tracheostomy and a percutaneous tracheostomy. A percutaneous tracheostomy requires this entire set. You require an entire set. Whereas a surgical tracheostomy will Now, before we understand how to do the percutaneous tracheostomy, we should understand the anatomy. So, Sachin, from top to down, what is the anatomy in your neck?
So from there it's thyroid.
Sorry?
Cricothyroid, sir.
No. Ashok?
Hyoid bone.
Very good. Hyoid.
Then
Alia? Alia? Very bad. Very bad. If you don't know this anatomy, very bad, because that means you don't know anatomy. Huh? So this is what your neck is. Okay. The top part, the top part of this will be the hyoid bone. You'll have the hyoid bone. Then you'll have the thyroid cartilage. You'll have the thyroid cartilage. So hyoid bone, thyroid cartilage. Then you have, after the thyroid cartilage, you have the cricoid cartilage. So the cricothyroid membrane is between the thyroid and the cricoid. Then comes your first tracheal ring, second tracheal ring, and so on and so forth. The approximate length of the trachea is 10 to 13 centimeters. That is the approximate length. 10 to 13 centimeters is the approximate length of the trachea. It's not huge, it's not pipe, it's a very small tube. 10 to 13 centimeters is not too much. That is the length of the trachea. So 2.3 centimeters is the width. Okay, 10 to 13 centimeters is the length. Okay, and there are around 10 tracheal rings that are there. Clear? Huh? So when you say ring, the only complete ring is actually the cricoid. The only complete ring is the cricoid. The rest are all incomplete rings. Now, what is the importance of having a complete ring?
Palpation.
Palpation is from the front. When I say complete rings means what is happening? You have the cricoid, say from the front. This cricoid has so much low. This is cricoid. It is a full ring. When I say trachea, it is a half ring. पीछे empty है. पीछे trachealis muscle चलता है. There is something called trachealis muscle. The trachealis muscle is there. There is nothing there. What are the implications for us as healthcare professionals? What you must understand is, tomorrow when you are actually having a patient who is probably going to aspirate or something like that, there is a maneuver. It's called a Sellick's maneuver, right? What does the Sellick's maneuver do? The Sellick's maneuver pushes the cricoid to the esophagus. Because there is a bone behind, you can actually occlude the esophagus. When you occlude the esophagus, the chances of aspiration is said to be reduced. Can you occlude with the tracheal ring? No. Why you can't occlude? Because posture is incomplete. That is why, as healthcare professionals in the field of intubation and emergency airway management, we need to know where the cricoid is. Understood? It is only the cricoid that will prevent gastric material from getting into your airways. Clear? Any questions? You've understood this? So from top to down, can you name it now, Ashok?
hyoid bone, thyroid cartilage.
So the biggest prominence is the hyoid bone. Then
Thyroid cartilage.
is the V-shaped cartilage.
Then the cricothyroid membrane, then cricoid cartilage.
Cricoid, and then comes.
Tracheal rings.
So I think you should see in each other how it is. So if I were to show it in him, or better hand me. Okay. So you have the hyoid. You have the hyoid. Then see, you press this. Put your hand here. This is the thyroid cartilage. This is the depression here, thyroid cartilage. Then as I come down, the biggest thing I see is the cricoid. This is the cricoid. Touch and see. Touch it, Chandrima. This is the cricoid. You see, this is the cricoid. So this is the thyroid. You can see the V here. Put your finger here. Inside. Can you see? There's a V here. So this is the. It's important to understand it as a V. It's a V. Okay, thyroid cartilage. Then you come down. The maximum prominence you say cricoid. Then you come down to the tracheal rings. Then you get the tracheal rings, and this cannot be felt very well because he's sitting in this position. Okay, so have a look at it. So touch. So you put the device inside, and then from outside you inflate the balloon. When you inflate the balloon opens up inside, and then it kind of dilates. That is called as Siagla's blue dolphin. Clear? Clear on this? Siagla's blue dolphin. And then the last technique, there are two more techniques of which you must know what is the percute twist technique. Percute twist. Okay, this also can be used in many areas. What is percute twist? You dilate and then you have a screw-like dilator. Okay, that means you dilate, then you put another dilator inside and you screw it as it goes inside, it becomes dilated. You understand? The skin becomes dilated. That is called a percute twist technique. Okay, there is one more technique, Fontana or something it's called, but I've never seen it. It is going from outside and going from inside. Matlab you put a guide wire from down and let it come from the endotracheal tube and all these things. So that I have not seen, I have not used, so I don't know about it. These are the techniques I have used. But this other technique in which you put, there is one more technique. There is one more technique in which you put a wire retrograde and do things. But we will not discuss something that is there. These are the things that are usually done. Okay, so I have not seen that other technique per se. Clear? Any queries till now?
So please repeat the techniques.
So the first technique is the Sear glass technique. That was the first technique. Sear glass multiple dilatational technique. Multiple dilatational. So what happens in Sear glass multiple dilatational technique? You start with the Seldinger's technique. Then you go from small dilator to bigger dilator to biggest dilator to most big dilator. You understand? And then you put the tracheostomy tube inside. Multiple dilatational technique of Sear glass. Clear? The second one is single dilatational. That is called as Sear glass blue rhino. It's called as blue rhino, where you have one dilator that becomes bigger, and you shove the whole thing inside. You open up a track and put the tracheostomy inside. That's called blue rhino. Remember it like the rhino's, rhino's horn. Okay. We have it showing. Let me see it. So that's called Sear glass blue rhino. Okay. Then the third technique that we talk is the Griggs technique, where we use a Kelly's clamp. We have a modified Kelly's clamp. Okay. Yeah. So this is the blue rhino. See this? This is the blue rhino. It's like a rhino's horn. Okay. So in this, what happens? You just go inside and you reach inside. Once you're done, you have reached this mark. You see the mark over here?
Yes.
You reach the mark over here. You are inside. You are perfect. Okay. Now you take this out and just put the tracheostomy inside. Or you put a guide wire through that and put a tracheostomy inside. Okay. This is actually comes with that entire set only. And it goes inside, and then you put the guide wire through it, and then through the guide wire you can put this inside. Okay. Simple. Clear? This is the blue rhino. लिखा नहीं है इसमें क्या? इधर भी.
इस पे dilatation.
Dilatational, it is written on that. What is written on that? So what is written on this is
Dilatation.
percutaneous dilation with blue line ultra. Blue line ultra. Treacheostomy. They have just changed the name to blue line ultra. Clear?
Blue rhino.
Is there here, right? And then the next technique that you have after the Griggs technique is the Sear glass balloon dilatational technique. In the balloon dilatation technique, what is happening? You put the dilator inside and then you inflate a balloon at a pressure, so the skin opens up. The skin opens up, get dilated, and then you put the next tracheostomy set inside. And the last technique that we talked about was the percute twist technique. Percute twist is you put in Seldinger's wire inside, then you put a dilator that has got serrations. I mean, जैसे screw में होता है नीचे वैसा, and then you turn it blue color का, turn it, it goes inside, and धीरे वो dilate होता रहता है. Clear? So that is the percute twist technique. There is one more technique with retrograde. That means you go from down, take out a guide wire, put down, but I don't know that technique. I really don't know that technique. Okay?
So why did you choose the Griggs method? What is the benefit
Of using the Griggs method. So this is more expensive. This is much more cheaper. But if you want to see which is faster, this would be much faster. Now what are the problems that you can face with the Griggs method? You can have major problems with all these methods. What is the first problem you can have with all these methods? What is the first problem that you can have with all these methods?
All these are blind.
Blind procedure. So bleeding was away. Apart from all the techniques or problems that we discussed, what are the other problems that you can have? You can have through and through puncture of the esophagus. You can have puncture through and through. You can form a tracheoesophageal fistula. You can go through and through. You understand? That's why don't be over enthusiastic in putting that. It can be very dangerous. Very dangerous it can be. Okay, you can have that. The other thing you can have is something called as tracheoinnominate fistula. That is the innominate artery and the trachea is in series together, and innominate artery करके artery है. और as time goes, innominate artery फट सकता है, and all the blood can go into the trachea. Tracheoinnominate fistula. we'll come to what happens when you have a tracheostomy fistula and what to do. So if you have a tracheostomy fistula, how will you recognize it? The moment you have, for some time there will be blood coming out from inside, blood, lot of blood coming out from inside, blood, actually arterial blood coming out. The only way you can get around this is by putting this further inside and superinflating the cuff. Okay, by putting this inside and superinflating the cuff. In any patient, if you have bleeding, what you should do is put the cuff and superinflate the cuff. If you superinflate the cuff, more often than not the bleeding will stop. Okay, inflate means you can inflate it much higher than what the numbers are. Okay, if you look at this, let's try inflating this one. So it is written on the cuff. If you see it is written on the cuff, the volumes. Okay, so what is the volume written over here? Tell me the volume written here. So how much do you think is the volume of this cuff? Huh? So the volume written over here is written over here. See, it's written over here, 24. Okay, but you can go more higher than that. Okay, so let's go more higher than that and see how much it goes. So let's put 10. 10. Okay, let's go higher. 10. 20. 30. 40. You see, he's on 40 and still you can inflate more. See, touch and see. See? You can still inflate more. So, see 50. You see this? You say super inflate is on 50. Okay, he's on 50. So it can go as big as this. Our trachea size how much? 2.3. So if you want to compress it, you can actually compress the trachea. You see? You can compress it. So you can go even higher than this. Let's not go back because we will require to use it maybe burst because it's the whole one. No? It can go higher than this. It can go higher than this. You understand, na? That is why you can never judge. You can never judge this size by touching this. You can never judge this size by touching this. Are you understanding? That's why you need a cuff pressure manometer. If you are managing your patient without a cuff pressure manometer, you are absolutely doing something that is wrong. Because you cannot touch and see the pressure enter. You can't do that because now there is a tracheal wall around this also. You don't know the pressure exerted. समझ में आ रहा है? Clear on this? You understood? That is why 3 times in the shift a cuff pressure manometer needs to be used. Why it needs to be used? If you don't use it, what will happen? There is a high possibility that it is overinflated. The pressures are very, very high. And when you say high pressures, means if the pressures are more than 30, there is a chance that the capillary perfusion will reduce because more than 30 venous capillary perfusion comes down. Okay, when capillary perfusion comes down, there will be tracheal necrosis. You understand? It's like a bed sore, no? In a bed sore, why are we worried? Why are we worried about bed sores? Because if the patient is lying like this, the capillary perfusion is coming down, and because it is getting pressed. Okay, because it's getting pressed, capillary perfusion is coming down. So you develop a pressure ulcer over a period of time, right? Similarly, in this also, the mucosal capillaries, which are even more thinner than your skin or subcutaneous tissue capillaries, it will very quickly come down, and this patient can probably have tracheal necrosis and scarred for life with a permanent tracheostomy. Nobody wants a permanent tracheostomy. Nobody wants a permanent tracheostomy. Clear? So this can be a major issue. We've seen many cases of permanent tracheostomy. So this is one problem that you can have. The other problem you can have is overzealous dilatation. That means after you have, so how do you do the tracheostomy? You first isolate where you are first, and now we know anatomically how to do it. We'll do it ultrasound wise also. You want to do it right now? Ultrasound wise to see where it is? Yeah. I'll show you. Switch this off for me. So the anatomy says that here you have the hyoid. Here this is your tracheal cartilage. Okay, tracheal cartilage. I'm coming down, and the largest bone that I get over here is the cricoid. So if I have to do a Selix maneuver here, this is where I'll be pressing down. Cricoid cartilage. Then comes your, up from here to here is your tracheal rings. Okay, so you have first, second tracheal rings that are over here. Clear? When you give the patient a position where you have put something and you have extended the neck, like for example, if you extend your neck, you can feel it much more better. Do it and see. So keep it straight. Now keep your hand and figure out the tracheal ring. Figure out. Cricoid रखो, उसके बाद में tracheal ring हाथ लगाओ. You're taking now? Yeah. You can feel it absolutely well if you only when you extend. Others you cannot feel it. Yeah. You want to try? Somebody wants to try it? No, you first keep it straight and now try to feel the tracheal rings. Now you tell him to extend and you get it properly. As I'm going.
Can you press U
UD
slash
UD
E?
flip.
UD flip.
Okay, so there's nothing here. Okay, there's nothing here. As we go down, what can you see? As you go down, let's see. Okay. So what do you see now? Just talk.
My name is Sachin.
See what happened to the vocal cords? It's moving. Can you see that?
No, sir. No.
So what you're seeing here
It's black.
is the thyroid cartilage. V. Can you see a V now? Huh? So you're seeing a V here. Huh? This is your thyroid cartilage. See that? See, now you talk now.
Hello everyone.
See, you see it moving? Huh? So that's your thyroid cartilage. Clear? Once more you want to talk? Huh?
Hi.
See? Okay, so thyroid cartilage. Now as you come down, see, can you see thyroid cartilage? V दिख रहा है तुम लोगों को? See, now you can see his vocal cords much better.
Yes.
Shall talk once more?
Hello everyone.
Okay. All right. So this is your thyroid because you see both the thyroids. You come down. Okay. Now what do I see now? I still see the thyroid. See the vocal cords. Can you see the vocal cords moving? See that?
Yes.
See that? Saw that? Huh? Vocal cords moving. Can you see it? Okay. Now let's go down. Okay. That's your vocal cords. See?
White.
दिख रहा है? Let's go down. As I'm coming down, what am I seeing here? So I'm now first seeing my first tracheal ring. Probably is going to come in over here now. First cricoid. This top one. Why is it going up? Why am I not able to see the top one? Here. Okay, here. So see that? Can you see? This is a thyroid. Okay. Let's see where we are. Okay. So here you have a cricothyroid membrane. Which one? Can you see this? You can see this reverberation artifact. So this is a cricothyroid membrane. Can you see that? The cricothyroid. So I am now in my cricothyroid membrane here. See that? There is nothing there. There is no air. There is just a reverberation artifact. Okay, see that? Okay, that's a cricothyroid membrane. Okay, as I'm coming down, this is my first ring. Can you see that? Tracheal ring. And then is my second tracheal ring. You see that? Second tracheal ring. So you see all of them at one stage. See this? This is the biggest one is here. You have the thyroid gland, V-shaped thyroid gland. As I'm coming down, I'm seeing the first. This is again the thyroid gland. Okay. Now I'm coming down. What am I seeing? Reverberation artifact.
Cricothyroid membrane.
Cricothyroid membrane. Reverberation artifact. Okay. I'm seeing the reverberation artifact. You can see it, right? You can appreciate it, right? Then that's not a bone. That's a reverberation artifact. And then when I'm coming down, there I get the bone. First bone. Can you see the biggest bone? This is the biggest bone I can see. Cricoid. And then I come down. What I see now here is the first tracheal ring. Second tracheal ring. So, and this is the third tracheal ring. So as you go down, you'll see all of them. Okay. Now what can you see on say the right side? Let's go and see what's on the right side. So what you see on the right side is what? Is the esophagus. You know, there's the esophagus there. You know, that's a carotid. That's a carotid. But you'll see the esophagus somewhere here. See the esophagus. That's the jugular. Okay, swallow. Got occluded leaf. Went off. It was there here. वापस. See? देखा? That's your. समझ में आया? That's a tracheal ring. Can you see? That's a cricoid. That is the cricoid, the white one. When you come down a little bit more, come down. See, that's the cricoid. Come down. Vocal cords आ गया. Come down. Come down. That's the cricoid. See? Can you see? That's the cricoid. Okay, that's the cricoid that you see. Now come down. That's the first tracheal ring. Hello?
Vocal process, and layer of
So so when I do a cricothyroidotomy, I know that I have to find the reverberation artifact. So I just go from the top. I'll figure out where my reverberation. See, this is I've come down. Okay, this is my tracheal ring. Okay, this is so above that is where I'm a cricothyroid. This is my cricothyroid membrane. Okay, where is it? Let's see. That's my cricothyroid membrane. So I just have to go through that. Okay, it's simple. Now the other way to do this is by actually keeping it linear. So when I keep it linear, what am I seeing? Okay, when I keep it linear from top to down. Okay, let's see. Okay, so you keep it linear. I don't know why I'm not able to see it, but maybe we'll use the other probe. Let's use the other probe. Here, and then you have 1, 2. Can you see this? Big hypoechoic region, and then you have multiple small ones. So as I go down, what do I see? See? 1, 2, 3. See? Huh? So these are the tracheal rings. Can you see that? And that's a tracheal ring that you can see. Right? So the largest one is the cricoid, and then you see the rings coming down. You understand? So that's how. But obviously, it is easier to do it from here. It is much easier to do it from here. You understand, no? If I keep this here directly, for some reason, no, it's coming only from the sides. Okay. So from the sides, when you're seeing, you can see this entire thing from top to down. See? Can you see the rings? Yeah. You can see the rings, right? Ring down. You can see that, right? That are the rings. Yeah. See? 1, 2, 3, 4. Can you see it? See? Can you see? This is the bigger cricoid one. This is first, second, third. Can you see? So it's very clear. You can see very clearly what we are looking at. Cricothyroid membrane. Here. So let's go ahead. So this is cricothyroid membrane. You can't see it as a reverberation artifact because of the fact that you have to see it like this. If you want to see reverberation artifact, to see it like this. See that? Can you see the reverberation artifact? Can you see it? That's a cricothyroid membrane. You understand? So it is actually very simple to do a.
Esophagus में tube है and trachea में tube है.
Easily you can do it. So if you want to keep this like this, you should see only one. You should see only one tube. अब यहाँ पर तुमको 2 ट्यूब दिखेगा because see this. यहाँ पर तुमको एक ही ट्यूब दिख रहा है ना because his esophagus is collapsed. You understand ना? You are able to see only one because his esophagus see that it's opened up and went down. वापस कर. See, open. See, it comes and goes, right? When you put a tube in the esophagus, you will have 2 tubes. You will have this as well as that seen like an artery and a vein. You will see like that because उसमें हवा आ गया है. You understand? Others, unless he actually deglutes, you cannot see the esophagus. It's a collapsed structure. You understand? It's a collapse. See that? It's a collapsed structure. You understand? ठीक है? ठीक है. Get up. Thanks. Our technique basically, which is called as the Green's technique, used with the modified Kelly's forceps, is this what we have? So we have a seeking needle first, a seeking needle that is there. Okay, a seeking needle. Okay, you may want to know whether you are in the trachea by another simple technique. Once you go inside, you attach your ETCO to side stream cable to this. Okay, you attach your ETCO to side stream cable to this. If you attach your ETCO to side stream cable, you will see some ETCO coming on top, which indicates that this is probably inside the. So the side stream means the one that you use for the GE ventilator. There are 2 kinds of ETCO2s, mainstream and side stream. The mainstream is the one that is the entire thing that is kept on the endotracheal tube, and the side stream or the microstream is the one that takes the tube from here and goes into the module. Okay, so GE ventilator has got the side stream one, whereas the Draeger has got the mainstream one. Clear? The blue one that you see is the mainstream one. Clear? So the first thing you do is delineate the anatomy. In any patient, first thing is you delineate the anatomy. After delineate the anatomy, it makes a lot of sense to actually mark it out. Okay, now in an ultrasound, if you want to mark it out, also it is simple. So when you go from the top to down, you take a needle. Okay, you take a needle. You take a needle. Keep the ultrasound like this. And if you want to know where to go to, just go with the ultrasound down with this needle. So you know exactly where you are because the needle will give you a ring down artifact. You understand? So once you get that, take out the ultrasound and go exactly in the center over there. You understand? You can even keep it vertical, the transfer vertical, and then go from this down, till you get that area which is between the first and second tracheal ring. Once you get in that area, you see this is where you want to go into. Okay? So with this, you will actually figure out where you are inside. With this, you'll figure out where you're inside. We normally want to use air. You want to use water. So you go inside, you figure out that you're inside. Once you're inside, you are only it's a very small hole, so don't worry about it. It's a very small hole. Okay, so you don't go through and through, but if you go through, so it's like a central line. No? You go in, unlike a central line, you press your to there. It's not like that. You do an ultrasound, look where it is, and go inside. With the ultrasound, you will know the depth also. You can measure the depth. When you're doing the ultrasound and keeping your ultrasound probe, you know that it is 1.7 centimeters or 1.8 centimeters inside. So you can visually figure out where you are supposed to go in. I understand, you can visualize where you are supposed to go because ultrasound gives you the depth, on the side there is a depth. So you'll know exactly where you are going inside. So once you go inside, you have reached that place where you get it. It is very essential to stop there. It is very essential to stop there and push only the push only the angio inside. You understand, only the sheath inside. It's very essential. You can't go inside, and then you might be in the esophagus. The moment that's why this continuous pressure on this is very important. Once you get it, immediately stop. It's like a central line. You don't go through and through. But in a central line, you may want to go through and through, like an arterial line. You may want to go through and through, and then you get a flashback. Then you take it out. No, how you do an arterial line many times? You take a cannula, you put through and through sometimes. You put through and through, you get a flashback. Then you slightly take it out. You get blood coming in, so you know you are inside the artery. Here you cannot do it like this. Here the technique involves you going inside with continuous pressure. The moment you get stop over there, and it's important that you know how to hold the needle in central line as well as in tracheostomies. It has to be held like as though you're playing pool. Your palm has to be clear. The palm has to be holding everything, and the needle has to be held like this. Okay, you always have to have one of the object in your hand all the time. It is important that you don't let go of any object because this can have problems if it slips inside. Okay, so once you go inside, you are out. Once you are out, the next thing is we actually bed number pushna. You have actually secured where you are. Then the next step is actually to put the guide wire in. Okay, the guide wire should always be prepared. Never put the guide wire on the patient's body. It can fall. Don't keep it on the patient's body. You are in a hurry to do things. You are in stress. Don't keep it on the patient's body. It's always better to keep it on the tray. So always keep this on the tray. Do not keep it on the body. It can be quite dangerous. You might slip. It might fall, and then everything will go for a toss. Okay. So keep it always on a tray. Okay, and keep it prepared. Keep it prepared. Don't leave it like this. Don't leave it like this. Keep it prepared. So you can keep it prepared by keeping it like this. Okay. Then when the time comes, you have to thread this through this, and as you thread it, there will be one place where there will be resistance. Okay. And the length of the trachea is 10.3. Around 10 centimeters. So you should be able to get it within short time. If you are keeping on going inside where you are in the esophagus. You understand? If you are keeping on going inside, अंदर जा ही रहे, रुक ही नहीं रहे, अंदर तक चला गया, पूरा अंदर तक चला गया, इधर चला गया. Where are you? You are in the stomach. You can't go in because it will not go in further because it has got a tip that is blunt. No, it has got a round tip. It will go in a butt somewhere. It will not go into the left and the right bronchus. You understand? Because this is only 2.3 centimeters. Look at the size of this. Clear? So it will not. So you are not supposed to. You cannot go inside too much. So that is the first thing. If the guide wire gets stuck in the process, if the guide wire gets stuck, like it goes inside, it gets stuck, don't try to pull the guide wire out. If you have to pull the guide wire out, you have to pull it out with this entire thing together. If I put this guide wire inside my patient, okay, if I put this guide wire inside and this is lying inside, now it is not coming out. This thing is not coming out. I have to take this out now because this has gone inside now. I have to take this out now. I have to take this out. So if this is not coming out, don't try to pull the guide wire. Don't try to do that. You'll have to take out the whole assembly together. Why is that so? Because if you try to pull it, it will abut somewhere and it will open. These are all springs. So if you look at it very carefully, there are springs on this. If you look at it, there are springs on it. So if I were to hold it like this, see like this, open it, there are springs on this. See? hold it and move it. Move it. See? Move it like this. See? You understand? There are springs on this. Maybe. So if you try to, if you understand, so if you try to pull it out, let it be this dilator, let it be this dilator, let it be that, it will abut against this and the springs will break open. If the springs break open, it is of no use. That guide wire is of no use. You are understanding, huh? It's got springs here. It's got springs in this. Okay, it is those springs that are keeping the wire the way it is, flexible and nice. If it goes inside, for example, if you put this inside, and it gets stuck somewhere, it's gone inside and it got stuck here. You try to pull it out. What will happen? The springs will get out. Springs will come out. Then it will there will be a fracture of the catheter. The springs will get into the system. You will get pneumonia. Things like that will occur. You understand? So the spring should not move out, right? Then, so the first thing we did is we actually put this inside. We put the guide wire inside. The next thing you do is you may want to use the red color. You may want to use the blue color. It's your wish. You can use this white color dilator and go directly inside. Okay, you can do that. Now you know the length as to where it should be. You know that you have measured it, that this is how deep the trachea is. So you know, once I reach this part, I don't need to now go perpendicular, I may want to go slightly slanted. Right? So I've reached this part and then I've gone inside. I've gone inside in one sweep, directly I've gone inside because I'm dilating. I'm dilating from here to here. Now this dilatation is small, no? This dilatation is very small. Once you reach inside, I will verify once more about air coming in from there. I may want to put ET dose if I want to, but I will know that I'm inside. Then the next step would be actually to rewire this inside. Rewire this inside, remove this dilator out. And after you remove this dilator out, then you use a dilator, the Kelly's forceps, the modified Kelly's forceps to force this particular thing inside. Now this you must understand is very similar to the Greeks, to the blue rhino. Just take the blue rhino out. So this is very similar to the inside of the blue rhino. So if you look at the blue rhino, see this. It's very similar to the blue rhino. This means to say you have to go inside at least to this area. And then once you reach inside, so the point is once you go inside, okay, then after that you turn the whole thing and you open up the forceps. So you go inside like this, go inside and then make it perpendicular and then you open up the forceps. Clear? You are first going inside, then turning it absolutely perpendicular so that you are inside like this, like the blue rhino how it looks, and then you are opening it up. Okay, once you open up, you have dilated it. Now here can be a very difficult situation. If you dilate too much, then you are breaking the cartilage. And we are not here to break the cartilage. Okay, and that will occur if by any chance your position is not proper, you are going somewhere else and opening up in a different plane. Instead of opening it in the same plane, you are putting it like this, and in the hurry to open it up, you are opening it up like this. If you open it like this, what you are going to do? You are going to actually break the cartilage. You will create a tracheostomy, you will be able to go inside. But later on, this patient will have large amount of problems with respect to tracheal, stenosis and things like that. If the cartilage breaks, you may break the arytenoid cartilages. There again, you will have a problem with respect to later on cicatrization, scar formation, and problems with respect to talking. So it's very important that you remain in the same plane. You remain in the same plane and not like this or like this. Because your others will open up the cartilage. You will make a hole. You will put a tracheostomy, but the long-term implications may be too much. So put it inside, go up straight, and open up the entire thing. Here, so if it goes from here, you go inside, open up the entire thing. Okay, so if it's this way, it's going inside, going here, and then once it goes up straight perpendicular, I open up this entire thing. Clear? Open up the entire thing, and then let the guide wire remain inside. Always remember to hold one of the tips of whatever thing is inside the patient's body. Okay, come out of the guide wire, and then use this directly. Through the hole over here, it has to go inside. It will come out through the hole over here and understand to open this. Opening this, many people don't know how to open this only. So to open this is very important. You know how to open this? Can you open this for us? Open this. See, so you understand. Now understand how it is. So if you try to open it like this, it won't come out. Okay, so open it and see. That's how you open it. Okay, so it's difficult to open it otherwise. If you don't know how to open it, it can be a problem. Shall you open That's how you open it. Okay, and it's important that you don't throw this away. Why it's important not to throw this away? Say tomorrow. First of all, you must understand that once the tracheostomy is done, don't try this tracheostomy. First of all, we know will not decannulate quickly, will not move out. Accidental decannulation होने के chances कम है. Why कम है? क्योंकि it is a percutaneous technique. Your skin is holding it. The skin is holding it. Okay, it's not like a surgical tracheostomy. So we don't need to stitch and all these things not required. You understand? But importantly, say after 4th to 5th day, you normally have a tract that is formed. So 4th to 5th day onwards, you have a tract that is formed. Till then, there is no tract formed. It is just a small hole that is there, and you may entail putting. If this comes out, it is don't do it yourself. If this comes out, if this percutaneous tracheostomy comes out, what will you do? If this, say today I did the tracheostomy in the morning. Okay, tomorrow morning you were on duty, and accidentally this tracheostomy comes out. What will you do, Hemant? What will you do? What will you do, Sachin? What will you do? What is it? The scenario is, I did a tracheostomy last evening. Today morning you were actually positioning this patient early in the morning, and this tracheostomy comes outside. What will you do? So what will you do? You are positioning your patient. Niharika is there with you on duty. What you all two will do? I will take this tracheostomy out and intubate this patient. I will put an endotracheal tube. You understand? I will not try to put this back inside. It is not acceptable to put this back inside before day 5, day 4. Okay, because day 5, day 4 से पहले track form नहीं रहता है. Since there is no track, if you try to put it blindly, see, remember this, what we were trying, blind technique. In the blind technique, we put a wire inside. Over the wire, we put a dilator, and after that, we put the tracheostomy tube. So the moment you take it out, collapse, either udar, skin will move here and there. There is no track form. And since there is no track form, before day 4, day 5, if the tracheostomy comes out, which is a possibility, when you are positioning a patient or something like that, there's a possibility. At that stage, what do? You just intubate this patient. Secure the airway first, because this can be done at a later date. You understand? The first thing you do is secure the airway, put in an endotracheal tube and wait. You are understanding? Don't try to reposition this. Patient might lose his life. Don't try to reposition this back inside. Clear? Clear on this?
So then in that case, after you've intubated the patient, when do you reattend?
Then we will call a surgical person along with us. So because there is a possibility, I might create a false track here. Okay, because now what happens is, the usual thing is, once you put the tube inside, you can actually feel it with your finger. You can actually see it. You can actually see the endotracheal tube. You can see the endotracheal tube in that hole. If you can see the endotracheal tube, the right thing is to put in a bronchoscope. Put in a bronchoscope. Okay, through the bronchoscope, see where you are. Okay, and with that bronchoscope, with the guidance of the bronchoscope, remove the tube a little bit. Put this inside. You will see the tube coming inside. You will see the tube coming inside. Once the tube comes inside, remove the endotracheal tube, remove the bronchoscope, you are fair inside. That's how it becomes safe. You understand? That's how it becomes safe. So usually that is what is done. If by any chance in the day 1 or day 2 it comes off, intubate this patient, call for a bronchoscope. Call for bronchoscope, because it is not this way that tomorrow you put a guide wire. You can't put a guide wire. You don't know where you are going. You're understanding? Because you have created there is something that is created, there is an incision, there is something has happened over there. So the anatomy is changed now. It becomes difficult anatomy. No? Since it becomes difficult anatomy, now that it becomes difficult anatomy, you can't use percutaneous dilatational technique. You can't go inside and put a wire and dilate. No, it's not possible. What you'll have to do? Intubate this patient, put a bronchoscope, and then pass this inside. That is the safest technique at that stage. You're understanding? Under visualization, that means. Under visualization. So, clear on that? Then it becomes safest. Otherwise, it is not safe. Otherwise, not safe. So, ideally, if you're at day 4, day 5, wait for some time. Then send for a surgical tracheostomy, because this is a complication. It's something that shouldn't have occurred. It is much more easier to call a surgeon and get it done. Okay, at that stage, because it's a complication. Clear? Clear on this? So, any doubts on the percutaneous tracheostomy we discussed? Any doubts on percutaneous surgical tracheostomy? Anything? Any doubts? Any doubts on this? So now I assume that you know everything about the tracheostomy, okay? I assume that you know everything about the tracheostomy. I think we should not make a mistake next time we are doing this tracheostomy properly. We should understand how to do it. Clear?